Hello everyone, today I'll be presenting on the use of low-dose aspirin to prevent preeclampsia. These are the learning objectives. By the end of this session, you should be able to describe preeclampsia, explain how aspirin helps prevent it, summarize key guidelines, and discuss the barriers to implementation, and also apply this knowledge through the case-based learning. This presentation is grounded in an article by Hawkins, published in the Journal of Obstetric, Gynecologic, and Neonatal Nursing in 2025. The author reviewed the evidence for aspirin prophylaxis and highlighted major gaps in practice. Globally, preeclampsia affects 2 to 8% of pregnancies and causes around 46,000 maternal deaths every year in the U.S. Hypertensive disorders remain a leading cause of maternal and infant mortality. Despite strong evidence, many eligible women still do not receive aspirin. Preeclampsia develops after 20 weeks of pregnancy. It's diagnosed when blood pressure reaches 140/90 or higher on 2 different occasions. It usually comes with either protein in the urine or organ dysfunction. If left untreated, it can progress into eclampsia, which involves seizures and is life-threatening. Burden of disease. In 2020, hypertensive disorders accounted for 7% of pregnancy-related to deaths in the U.S. For mothers, complications include stroke, kidney failure, and placental abruption. For infants, risks include preterm birth, stillbirth, and growth restriction. These outcomes highlight the importance of the prevention of preeclampsia. How does aspirin works? The mechanism isn't fully understood, but here's what we know. Low-dose aspirin irreversibly blocks COX-1 in platelets, reducing thromboxane A2, which normally promotes clotting and vasoconstriction. Prostacyclin remains active, encouraging vasodilation and anti-clotting. The result is better uroplacental blood flow. Aspirin also dampers inflammation and stabilizes the vascular lining. Timing is key. It works best when started before 16 weeks. Guidelines and recommendations. These recommendations come from the 3 key organizations: the U.S. Preventative Services Task Force, the American College of Obstetricians and Gynecologists, and the Society for Maternal Fetal Medicine. They all recommend 81 milligrams of aspirin daily for a risk woman, starting ideally between 12 and 16 weeks and continuing until delivery. To decide who qualifies, we assess risk factors. Just one high-risk factor is enough to recommend aspirin. 2 or more moderate risk factors also qualify. Examples of risk factors include history of preeclampsia, twins, chronic hypertension, diabetes, kidney disease, or autoimmune conditions. Moderate risk factors include being a first-time mom, obesity, advanced maternal age, family history, Black race or low income due to structural inequities, and IVF conception. The standard dose is 1 baby aspirin, 81 milligrams daily. It should be started ideally between 12 and 16 weeks and continue through delivery. Studies show no increased risk of postpartum bleeding or placental abruption. Effectiveness depends on adherence, so nurses play a key role in reinforcing daily use. Nurses are central to implementing this prevention strategy. We screen for risk factors at the first prenatal visit, educate patients about the benefits and safety of aspirin, encourage adherence strategies like using pillboxes or reminders, and advocate for system-level support such as EMR prompts to ensure at-risk patients aren't missed. Let's walk through the scenarios. Case A, first pregnancy, age 36, obese case, that's 3 moderate risk factors. She definitely qualifies for aspirin. Case B, twins and chronic hypertension, both are high risk. She automatically qualifies for aspirin. Case C, first pregnancy, black race, Medicaid insurance, that's 3 moderate risk factors she qualifies as well. Here's the key distinction. We are not diagnosing preeclampsia here. These patients do not have to have the disease yet. What we're doing is identifying risk factors early in pregnancy, and that alone is enough to start aspirin. Aspirin works as a preventative therapy. We do not wait until blood pressure goes up or the protein shows in the urine to start prevention. Prevention starts with the risk identification. Now, let's contrast that with actually diagnosing preeclampsia. Diagnosis is made after 20 weeks when blood pressure is 140/90 or higher on 2 separate occasions 4 hours apart, and either proteinuria is present or there's evidence of organ dysfunction, such as low platelets, elevated liver enzymes, kidney injury, pulmonary edema, or central nervous system symptoms like headaches or vision changes. So remember, identifying risk is enough to start aspirin for prevention. Diagnosis is equal to confirming the disease once symptoms and clinical criteria appear. Now, let's finish this session with some key takeaways. Preeclampsia is a major threat to maternal and infant health. Low-dose aspirin is effective, safe, and underused in practice. Remember that identifying risk factors is not the same as diagnosing preeclampsia, but identifying risk alone is enough to start aspirin for prevention. Nurses are on the front lines. We screen early, educate patients, support adherence, and advocate for those cases that are not treated with equality. Ultimately, early risk screenings and consistent aspirin use can save lives. Thank you for watching. These are the main references used to build the presentation. The Hawkins article was the foundation, along with the U.S. Preventative Services Task Force recommendations, ACOG and SMFM guidelines, and a systematic review by Henderson and colleagues in JAMA. Together, they formed the evidence base for recommending low-dose aspirin to prevent preeclampsia. Thank you.